Hello, I'm Dr. Ghosh. I'm a doctor for about 44 years now, and I've been doing cardiology for a long time. I was a very busy clinical and interventional cardiologist, but for the last 23 years, I've switched to non-interventional cardiology. And the last 20 years I've spent in Apollo Hospital in this particular department, and we have brought it up to the kind of state that it is in. It's one of the best in the country, 100 plus echoes, which includes about 15 to 20 vasculars. It includes 30 stress echoes. It includes about 15 to 20 carotids, a lot of portable echoes, a lot of hemodynamics in echoes. So it's a lot of things that we do here, and you can imagine the experience over these 20 years that we have in doing all these things. And now, what I'm going to talk about is basically what is the problem in cardiology is coronary artery disease. And I'm going to tell you how non-interventional cardiology helps in the process of diagnosis of this problem. It's good that I'm starting out with coronary artery disease, and I'm basically going to tell you the 4 different kinds of evaluations that the non-interventional cardiologist does to see for coronary artery disease and where they are applicable to you. One of them is the stress ECG, which is very common, which you normally call as the treadmill test, and which a lot of people are conversant with. And the only things that you need to know is that it is at best a good screening test. In this particular hospital, there is a very busy preventive health check package which deals with doing a lot of treadmill tests, up to about 80 to 100 a day. So that's a lot of work, but what should be known is it is a good screening test to find out about coronary artery disease. It's a good screening test to find out your exercise tolerance so that you can use it in your day-to-day activity. But it really doesn't have the kind of predictive value or accuracy to diagnose coronary artery disease more than 50%. So that's how much of importance that you must give to this test, and it at best is a screening method. The next thing that I want to tell you is about the stress echo and the W-beam stress echo. They have a sensitivity and specificity of 85 to 90% in trying to tell you that whether you have or you don't have coronary artery disease. Now, it's a very rapid test compared to the other tests. It's done online. You get a report immediately. We do it without any appointments, and patients who come as and when they come, and you go back with a report telling you whether what is the problem. And the sensitivity and the specificity of the stress echo is about 80 to 90%. And in our hands, I will say it's more than 90% out of the sheer, the experience that we have, and also the fact that, it's observer related, and that comes with long experience. And here in this particular hospital, we are doing all the stress echoes ourselves as cardiologists, very senior cardiologists, which is not done anywhere else. This third test is called a W-beam stress echo, which is done when a person cannot walk for various reasons, or is prevented from walking, or does have what is called as LV dysfunction, or the heart is large and the heart size is, the ejection fraction is less. So in these kind of people, we do it with injection, and here again, we do it online. We tell you the report straight away. We give the patient the report straight away. So they go back in the same setting from the doctor to the test and back to the doctor to decide on further course of treatment. That's what you should know about the W-beam stress echo. The last, which is not done by us, but I'm telling you about it, is called the stress thallium, or the nuclear cardiac imaging. Well, this is done to evaluate coronary artery disease, but you have to understand that it has about a cost that's twice to 2.5 times what our stress echoes or W-beam stress echo cost. It takes time, it takes an appointment, right? It's more costly, and then you have to wait for the report, right? And what you get in benefit is, it may be a little bit more sensitive, right? So it is good for single vessel disease, and it actually doesn't see what is called as ischemia. It sees what is called as coronary flow reserve, or the reserve or the capability of the arteries to increase their blood supply with stress. So it has got specific indications, but I will say what should be used as a run of the mill, what should be used frequently are the stress echoes, because according to us, the sensor very specificity of the stress thallium is as comparable as our stress echo is, at half the cost and at a rapid speed.